I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. Before we start, we'd like to the Ramaytush Oolani people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Oolani elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We're proud to continue the tradition of coming together and grow as a community. We thank the Ramaytush Oolani community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Excellent. Okay, perfect. Well, today we're honored to have Dr. Elaine Koo speak to us on accessing and utilizing national health data sets in addressing disparities with a focus on hypertension and chronic kidney disease. Dr. Koo is an associate professor of medicine in nephrology and co-director of the training and clinical research program in the Department of Epidemiology and Biostatistics at UCSF. Her research program focuses on understanding differences in the epidemiology, clinical management, and outcomes of children versus adults with kidney disease, and the conduct of clinical trials to test interventions to improve survival of patients with kidney disease. She's especially interested in transition of care, such as that between adolescence and young adulthood, as well as between advanced chronic kidney disease and end-stage renal disease. And she's currently working on addressing cardiovascular risk in patients with kidney disease, disparities in accessing kidney transplantation and transplant outcomes, and also risk factors that are associated with progression of chronic kidney disease. Dr. Koo, welcome, and we look forward to your presentation.
Thanks for your introduction, and thanks for inviting me to speak today. So I'm going to focus on the use of public databases to conduct clinical research. I'll go through the steps to getting access to these public databases, as well as how you might use them to build your research questions, as well as career. Just make sure I can forward here. I do have some disclosures. They are not relevant to anything that I'm going to be speaking about today. And I think we will take questions at the end. So please do hold on to your thoughts, and I'm happy to answer any questions. So public databases have always existed. Certainly the NIH has always been very interested in data sharing. And if you have large national cohort studies, you are often asked to share the data after the completion of your trial or cohort. But I think that with the 2023 changes to data management and sharing policy, there's going to be even more sharing of data as time goes along, and there will be more and more opportunities to use data that are available to conduct research. And so I do think it's an exciting time to figure out how you might leverage some of these publicly available databases to answer your questions or design your grant and research. So I put together a couple of considerations that you might want to think about when you are using public databases for research. So things that might matter quite a bit is the quality of the data that's actually available. And that will vary depending on what the source of the data is that you're trying to use. Whether or not that data access comes at a cost versus not will be important. Many of these public databases are actually free, but there are some databases that do require a fee for use or a fee for acquiring the data. And so depending on how much resources you have available to invest in acquiring the data, that might be something that you'll want to consider as to whether that data set is appropriate. In addition to that, types of data that are available, whether it will truly answer the question that you're interested in, will be important. You also want to think about the source of the data and where it's coming from. And that's important because people invest varying degrees of time to clean the data so that they are usable for the public. And so obviously, the cleaner the data, the easier it is for you to answer your research question. And the annotation really varies across these databases in terms of the data dictionaries and whether or not you're going to be able to understand how to use the data. And so that's also important. Other things to think about are accessibility. Where is the data accessible? Can you actually download it onto your own server or desktop and use it versus you have to use it within a VPN environment? And I'll go through some of those opportunities. It can be a little bit more challenging when you can't actually download the data for your own use and use your favorite statistical program to analyze the data. That's something to think about, but some of these data sets are live within controlled access spaces. And then lastly, you'll want to consider whether or not you have any familiarity with the data and the learning curve that it's going to take in order for you to be able to use the data to answer the question that you wish to answer. So it's always best, in my opinion, if there is someone that you're working with who is familiar with how the data was acquired or they were part of the original study. Because sometimes when you're looking at these public databases, it's not entirely clear what's going on. And so having that resource for someone who really knows the data well or was part of the protocol can be really essential so that when you're performing your analyses, you don't want to understand the data and publish information that actually isn't using the data correctly. And that's happened a couple of times with people who are using public data. And of course, when you're using public data, lots of people have access. And so sometimes those errors can be picked up a little bit easier because lots of people have access to the data and may point out that, oh, you should have done X, Y, and Z because this is how the data was actually collected. So just some thoughts to think about as you're contemplating whether or not it's worthwhile for you to invest your time in acquiring some of the data. So I'm going to start off with what I think are relatively clean data that are tend to be pretty easy to use, and that's the data that's available within NIH data repositories. I've given you the link here. This one happens to be the NHLBI's data repository. And so when you go to their website, you will see, as in most of these data repositories, that there is an area where you can search for data sets or biospecimens, depending on what topic it is that you wish to acquire data sets for use. And so I've typed in hypertension, and so you can see that I got a bunch of databases that are actually available within the NHLBI data repository. This ranges from trials that have been closed. All had was the trial that was completed probably now more than a decade, if not two ago. And so you'll see what that these repositories will tell you whether there's only data available, whether there are specimens and data available within the open data repository. So this is an example of a list. I didn't copy the entire list because it was quite long in the NHLBI, but the DASH study is in here. The SHEP study, which was conducted many years ago on systolic hypertension in the elderly, is in here. When you're requesting the data, almost with all of these repositories, what they'll ask for is pretty standard. So there will be a data request form that you'll fill out on the actual repository website. You'll need to provide a very brief description of the research plan and protocol. And generally speaking, this research plan and protocol is not like a grant. So they're looking for just very brief descriptions of what you plan to do with the data. A very brief analysis plan. And so it doesn't need to be super elaborate. And as you're using the data and you download it, if you change the plan, generally that's okay. Although they do review manuscripts before you submit for publication. You'll need some documentation or review from an institutional review board before you use the data sets. Even if your institution determines that the data sets are completely de-identified and therefore not considered human subjects research, that is perfectly okay. That is usually what our IRB has often said, that these data sets have been scrubbed of all patient health identifiers, so they're not considered human subjects research. You'll still need to go through the process of getting a letter from the IRB saying that it's not human subjects research versus having a determination that it's exempt, and you'll need to supply that to these repositories. And then lastly, there's usually a research materials distribution agreement that will need to be signed by the principal investigator and your contracts and grants office. It's pretty standard language. Most of the time, these data user agreements cannot be changed. There's no negotiation on the language per se. But this is to acknowledge that your institution knows that you have this data, that you're going to keep the data in a safe place, and that you're only going to use it for authorized purposes, etc. That's the general steps to getting access to the data. One of the benefits of using repository data is that there have been a number of calls almost every year for grants that actually use the biospecimens that are actually stored in many of these repositories for almost every NIH institute. And so certainly these are opportunities for you to ask to perform additional assays on the specimens that have been stored and are linked to data that are actually available within the data repositories. If you're interested in requesting specimens, so I've done this only once before, but you would complete a specimen request form. And so first thing is to let the NIH entity know that you're interested in X specimens. And then what they will do is look for how many specimens they actually have available. So these are biobanks. And so people have used up oftentimes some of the baseline samples. They don't have the full amount that they had originally banked because it was used for different assays. So depending on whether you're interested in performing assays on baseline specimens versus follow-up specimens, you'll tell the entity, I need X amount of a specimen that was stored in a red top tube from these visits. And they'll do a query of their biobank and make sure that they actually have the specimen available for you. Once they confirm that they have the specimen available and that you could potentially run the assay that you wish to run on these specimens, then you'll need to get documentation from the IRB that this is approved. And so you'll go through an IRB review. You will usually provide a study protocol that tells the entity what your aims are, what the analytes or parameters to be tested are, what kind of assay you're going to perform, what kind of platform will be used, why you need the specimen, and your power calculations, so that they can determine whether or not this is a good use of these precious specimens that have been stored. And then just like for the data, you'll fill out a material and data use agreement with the NIH before you can run this. And then you may need to tell them where to ship the specimens, depending on what assay you're actually running, so that the lab can run the assay for you and return the results for you. And oftentimes at the end of your project, you'll be asked to share the results from these analyses so that they can be shared with the public for additional use. So I'll now sort of go through, assuming you have access to the data, that's the steps to acquiring the data. I'll now go through an example of how you might use the data. So we'll start with the data dictionary. So when you're in any kind of repository data set, at least from the NIH, this is the website for the SPRINT trial, which of course was the intensive blood pressure lowering trial that has been made available. A couple things that you'll see on the repository page. So on the right-hand side is pretty important information. It tells you what materials are available from SPRINT. So there's DNA, there's plasma that's been stored, there's serum urine, etc. The study documents on the right-hand column are pretty important. So even before you apply for the data, looking through the data dictionary can be super helpful because it will tell you whether or not the variable that you're interested in is actually available within the public data set. So even though all the studies are supposed to share their data, sometimes there are certain sub-studies or sub-portions that they did. For example, if they did imaging only on a subset of participants, that doesn't always get shared in the repository, or there may be delays in sharing that data. And so the data dictionary gets updated, and that's the best place for you to see whether or not the variables that you're actually interested in to answer the study question is actually available. The other documents that are pretty important on this right-hand side here include the SPRINT forms, which I'll show you in a second, as well as the current protocol and the manual procedures. And that's where you may get the answers to many of your questions about, did they do X? How often did they collect X? How often did they see participants and measure blood pressure? And that information would be available within the study, the protocol. On the bottom here are consents. So it gives you a pretty brief overview of whether or not when they consented the SPRINT study participants, whether they consented to genetic use of their specimens. And so if you're interested in genetic studies, for example, that really tells you how available these biobanks may be for you to conduct genetic studies. So this is from the SPRINT protocol. So in that right-hand column where I showed you, if you clicked on the link, you can download the protocol. I usually go to this table first because it tells you a lot about how often they were collecting certain data. So for example, genomic material was collected at randomization and screening and then not collected thereafter. Chemistries were collected fairly often. You can see that they got blood pressures at almost every visit. And then physical exams were done at set intervals. And so this gives you a pretty quick overview of whether or not the question you're trying to answer has enough of the data that you're actually interested in. If you open up the data dictionary, this is one example that I pulled from the data dictionary, but in almost all of these public data sets, there's a scrambled identifier that links all the data sets. In this data set, it happens to be called the MASC ID. Most of the more recent data sets don't have dates in them. They have time. So you can see that the form days tells you the number of visit days post-randomization that any of these variables are actually collected at. And so that would be your time variable. There's usually some sort of visit code that tells you, is this a baseline visit? Was this a follow-up visit? Which follow-up visit was it? And so you can see here on number 4, there is a visit code. Here it looks like they're collecting some information about smoking. They're collecting some information about diabetes and some information about insulin. And just looking at this, data dictionaries, again, sometimes it's not clear, well, how often were they collecting this? Was this from baseline or was it from a follow-up visit? And that's where going back to the protocol and trying to see when they actually collected this information is important. But paired with that, when you're looking at the data dictionary, it's also important to check the forms that match with each data set. So you can see here that the form where SPRINT collected some of this information, the question was actually, how is your diabetes being treated? Check all that apply. So is it pills? Is it insulin shots? Is it diet and exercise? They were asking, since you've been part of SPRINT, has a doctor or other health professional told you that you have diabetes? And the answers are no, yes, and unknown. And so if you go back, you can see that that matches with number 12 here, where the abbreviated label is, as a doctor or healthcare professional told you that you have diabetes. And so you would match that up with the form. So the forms are pretty important because it gives you a better understanding of where did the information in that data dictionary come from? How did they actually ask the question? And then you compare that with the visit code here to see when that information was actually time updated over time, should the diabetes variable be something that is of importance to you. For example, your research question might be, how many people in SPRINT eventually develop diabetes? And so that's how you might use this. Okay, here's another example. So this is an event file. So what I pulled earlier looks like it's the medication and physical exam file, but here is an event file. So these are kidney events from SPRINT. So the first thing you'll notice is that all the data sets can be linked by the MASC ID, which is the scrambled identifier. So if you were to merge data sets, that's how you would merge by, so that you can link the smoking variable that we saw earlier or the diabetes variable that we saw earlier to events of interest. Here, again, there are typically no dates in the more recent public repository data sets. There are just days from randomization. And so here, your time variable for an event such as onset of albuminuria is actually here in the event days. Here you have follow-up for urine albumin to creatinine ratio. you have doubling of urine albumin to creatinine ratio. That's an event of interest. And so you compare this with the baseline file in order to ask the question, for example, if you were interested in how many people doubled their urine albumin to creatinine ratio from randomization over time. The NIH-LBI isn't the only NIH institute that has these data repositories. The NIDDK has one. The NINDS also has one. And so here I'm pulling you a different website. They all look a little bit different in terms of their structure, but the information is generally the same. So here, for example, they're telling you that they have data from the ASK cohort study, that specimens are available for request. If they were interested in adverse events following angiography, the PRESERVE trial data is in here. You can see that this one's not yet available, so internal use only, but the presumption would be that over time this would become available, etc. So it tells you the status of those public data sets. Again, this is the NIDDK's format, but this presents the study, just like I showed you earlier for SPRINT, but on the right-hand column is that important information. It tells you that for the ASK study, there is serum, urine, and frozen plasma specimens that are actually available. Again, you have the data dictionary that you can look through. There is usually the manual of procedures, as well as the cohort protocol for you to look at as you're trying to decide whether or not this is a good avenue for you to conduct and answer the research question of interest using publicly available data. So I'm going to show you some of what we've done before, just to show you a flavor of what's possible when you're using NIH public data. And so my group has been very interested in what is the appropriate blood pressure target for patients with chronic kidney disease. And of course, during the original SPRINT trial, in terms of the kidney outcome, there were very few kidney events, so onset of dialysis. And so you can see here that in the actual SPRINT trial, when they published their data, there are wide confidence intervals looking at intensive versus usual blood pressure control in the SPRINT participants. And you couldn't really make any conclusions about whether lowering blood pressure is beneficial for patients in terms of their kidney outcomes. Of course, in SPRINT, for mortality and for cardiovascular outcomes, they did have enough events, and so that was a statistically significant finding, but not so much for kidney. So a lot of our work is actually what should the blood pressure be for patients with chronic kidney disease. And I'm particularly interested in patients who have stage 4 or 5 chronic kidney disease, so advanced levels of chronic kidney disease. And so we wanted to do a meta-analysis, putting together all the trials that have actually asked this question. And so certainly, if you wanted to do a meta-analysis, one way you could have done this is you could have asked each of the trial investigators for their point estimates for patients with chronic kidney disease by stage of chronic kidney disease, put that together, and of course, done a meta-analysis in that way. But we thought we would use repository data. So we had some collaborators in almost all of these trials. And so we searched all of the NIDDK, NIH-LBI, and NINDS data repositories to see whether or not these trials were actually in there. And we identified at least 4 that we could actually put together to conduct analyses with. And so you can see here that we were actually able to gather all these baseline characteristics from the NIH data repository trials. We put them all together and did an individual level meta-analysis. And so you can see that there were 5,800 patients that we were able to put together to conduct this analysis. And we did have 2 trials that we had collaborators actually give us the data that were not from the repository, but that just gave us a lot more kidney outcomes, although we still did not find statistically significant findings. But this is certainly an example of a study that is done almost primarily by public data. We were particularly interested in stage 4 to 5 CKD. And so one of the benefits of being able to amalgamate the individual level data and put it together is that we could look by baseline GFR, and particularly those with GFR less than 30 at baseline enrollment, which is always a subgroup that's often excluded from trials and too small to actually find statistically significant findings. And here we did see that intensive blood pressure control was particularly beneficial for patients with stage 4 to 5 chronic kidney disease. All this to say that this would have been difficult to do had we gone to each individual trial group, because many of the trials are now closed and the groups are no longer operating, including MDRD and AST trial. Those are trials that were conducted more than 2 decades ago. And so having someone try to give you the point estimates to conduct the meta-analysis might have been a little bit more difficult, but we were actually able to use the repository data to conduct this analysis. And so with the repository data, you do need to submit your manuscript to the entities that provided you with the data prior to publication. And then usually there is a statement on the website that they want you to include for each trial or cohort study that you're actually using. And so it's important to check and see which statement is appropriate for the data sets that you're actually using before you actually submit for publication. This is another example of some work that we did using the repository data. So we were really interested again in blood pressure control in young adults with chronic kidney disease. And we wanted to know whether or not young adults should have their blood pressure intensively controlled, but we could not find any good data sets that had really, really long follow-up for young adults, because of course, cardiovascular and kidney outcomes take many decades to develop. And so what we did find, though, is that there was a data set, 2 data sets that had looked at blood pressure control in the repository. One is the core trial, which is certainly in the repository that you can use to do analysis. But of course, the core trial was a trial that was conducted now more than a decade ago, showed that there was not really a benefit for intensive blood pressure control. And this was conducted in older adults. But we really wanted to ask this question in younger adults. So for older adults, intensive blood pressure control was not found to be beneficial. So what we ended up doing is we identified a data set in the repository, the DCCT or EDIC study, which some of you may know is a now 30-year plus study that had originally enrolled patients with type 1 diabetes. And so we thought it would be kind of interesting to look at blood pressure in this study. So this study now, back in 2014, had 28 years of follow-up, was started many decades ago, and was an intensive glycemic control trial, so looking at 2 different hemoglobin A1C targets. But we thought, well, why don't we look through the data dictionary and see whether or not we can do something with blood pressure, which was not the original intention of this trial or study. And so we looked through the data dictionary, we found that they had actually really good blood pressure measurements during the entire follow-up period, and they had really good outcome ascertainment for kidney outcomes. And so we designed a study leveraging the trial data to do more of an observational cohort study, where we wanted to look at the effect of blood pressure control or achieved blood pressures on outcomes such as macroalbuminuria and chronic kidney disease. So there was a learning curve to this data set. We did get someone who was involved in the DCCT trial originally to help us understand the data and what the limitations of the data are, as well as how to use the variables. But you can see that we were able to split up this cohort by their baseline blood pressure when they entered the DCCT study. And then we were able to link their time updated blood pressures on the yearly visits, which are all available in the repository, with outcomes such as macroalbuminuria. So here we're showing that the higher the blood pressure is, the more likely you are to develop macroalbuminuria over time. This is diastolic blood pressure and albuminuria, which shows pretty much the same thing. And this is the risk of chronic kidney disease, again, over this 30-year follow-up period. Again, higher blood pressure is associated with higher risk of chronic kidney disease. So that's another example of what can be done. I'm now going to shift slightly to other cohorts that have blood pressure data in case you're interested in hypertension. There are two nice cohorts with chronic kidney disease patients in the NIDDK repository. This one is a pediatric cohort that also has 20 years of data collected already that's actually available for your use, and they see patients annually to ascertain people's blood pressures. And so we've certainly used this to look at how this blood pressure, they have actually 24 ambulatory blood pressure monitoring data in this pediatric cohort. So we were looking at how this clinic versus ambulatory monitoring blood pressure data associate with the risk of developing end-stage kidney disease. And again, this is all using repository data. We did have some collaborators who are part of the original chronic kidney disease in children study. But this did not go through the actual data coordinating center, which may cost more if you're trying to do a study going through the observational cohort's own data coordinating center, which is actually still operating. The study is still ongoing. But we were able to just use the NIH public data set to conduct this study. The parallel adult study that has 20 plus years of follow-up is the chronic renal insufficiency cohort study, which is also within the repository, and it has a lot of specimens collected that may be available. And so this study actually looked at things like depression and cognitive function over time, in addition to collection of data on kidney function, as well as quality of life and also blood pressure, and can be a very useful resource if you're interested in any of those parameters in terms of your study question. We've used this adult study as well, again, through the repository and not through the actual data coordinating center, which is still operating. The CRIC study is still ongoing currently, but we looked at use of different antihypertensive agents as people progressed through different stages of chronic kidney disease. And so this was also done through repository data. And both of these data sets, I would say, are very well annotated. So it's quite easy to use and figure out which variables are available to answer questions. Okay, I'm now going to shift away from NIH public data repository to share with you some other publicly available data that might be useful if you're interested in hypertension or chronic kidney disease. The first one, and it's not an NIH data repository that I'll share with you, is the US Renal Data System, which you may or may not have heard of. The website for this, the access to these data is below on this slide. But this is a national kidney disease registry. And so all patients in the US who develop end-stage kidney disease, whether they are on dialysis or have received a kidney transplant, are required to submit their data here. And so this is free. So for researchers, you can put in a simple data request as they describe here and get access to this data. Where you might want to start is to look through the researcher's guide, which explains to you what the data looks like and how the data is collected. Appendix B is quite useful. It has all the variables that are available within the US Renal Data System. And so you can look through to see whether or not it has predictors or outcomes that you might be interested in. And then Appendix C tells you how each of those variables are actually formatted. And so the types of data that are available in here, there's over 2, if not 3 million patients now in this database. There is good collection of dates of dialysis, waitlisting for a kidney transplant, as well as ascertainment of death. All of the patients who have Medicare, they've been linked to the Medicare claims file. And so you can look at questions like how often are people being hospitalized? There's Part D medication prescription data in there. So you can ask questions of which antihypertensive agents are being used. You can see coding for reasons for hospitalizations and emergency room visits. You can also look at healthcare spending if that's something that you're interested in, so long as the patients that you're interested in are limited to those with Medicare insurance. I pulled an example of someone who has used this data before to look at a question in hypertension. So this was looking at the use of antihypertensive medications in older adults as they transition from the advanced stages of chronic kidney disease to needing dialysis. And so these investigators were really interested in patterns of antihypertensive use in the 1 year before and the 2 years after instant end-stage kidney disease onset. And so because this required prescription fill data, they were looking at were people filling their antihypertensive prescriptions and which ones were they using. This only included patients who had Medicare Part D, which meant that these tended to be older patients. And so I think they only included patients over 67 years of age. But here's an example of the demographic data that are actually available within the US Renal Data System. I think this study included over 13,000 patients. So one of the benefits of the US Renal Data System is there's a lot of power because there are a lot of patients in this data set. So you can see that the mean age is 76 years in this study. You have what year they started dialysis and how they were being treated. But this is an example of the types of analyses that you could do using this data set. So again, this is using prescription fill data from Medicare Part D. And so they were able to ascertain what happened on a quarterly basis to use of beta blockers, calcium channel blockers, diuretics over time. And then in figure B here, they're linking it to outcomes that might be associated with these antihypertensive agents. So onset of acute kidney injury, heart failure, hyperkalemia, etc. Certainly NHANES, I think a lot of researchers are familiar with. This is another publicly available database that I'm not going to spend too much time on, but you can get access to the NHANES survey data, and many investigators have used this to actually conduct research related to hypertension. Again, there are data sets and documentation of the data sets. The one thing you'll want to be careful with NHANES is that you do need to apply weight in order to get estimates that are representative of the US population. And sometimes people forget to apply the appropriate weights when they're actually looking at these data sets. But certainly this is a nice resource, and this resource dates back many decades. And so you can have many years of data to look at. And I think one of the strengths of this data set is that you can really look at trends over time and answer good epidemiological questions if that's something that you're interested in. Again, I pulled someone else's paper here where these investigators were using NHANES data and looking at control of blood pressure, as well as what people were doing in terms of taking antihypertensive medications. And I'm not going to belabor the actual science in this manuscript. This is just to give you an idea of what might potentially be available for you within the NHANES data set. I'm going to talk about a data resource that you may or may not have heard of that is a little bit newer, and that's YODA. So YODA is the Yale Open Data Access platform, which is a little bit newer. We do have, my group has access to this, and we're still learning how to use the data. But YODA is an open data access platform. There's more than one platform that is similar to this. But if you're interested in trials that were conducted particularly by industry, YODA may be a very nice partner for you in terms of getting you access to that data. So on the website for YODA, you can see that there are examples of studies that people have been able to do, so including SGLT2 inhibitor trials, which are really primarily sponsored by industry. So you can see that people have published using the data that's available through YODA. So YODA is a platform where the analyses are primarily done through their secure VPN access. And so you do have to work within the environment that they give you access to. But it has hundreds of trials in here, including some of the most recent ones. And if the data sets that you're interested in are not necessarily NIH sponsored, but industry sponsored, then this is one place where you might want to search for the study and see whether or not they've actually deposited their information or their data into the YODA platform. I provided with you, again, the steps to getting access to this data. There's no cost to accessing the data. And so you would read through their policies and procedures, go through the trial list and see whether or not they have the data sets that you're actually interested in using. You can then acquire a login, and then you will fill out a conflicts of interest form and do a very short data use agreement training module. You submit a research proposal, and then depending on what you're trying to do and which data sets you're trying to access, they will review that and they may come back and ask you some questions, and then you submit your data request and you should get access to the platform. So I pulled up examples of some of the studies that are in here. So some of the GLP-1 as well as SGLT2 inhibitor studies are actually already deposited in here. And so if that's something that you're interested in working with, you can actually try to request access to YODA. There are sometimes some charges depending on what you're trying to do with the data. But we were trying to actually put together some of the SGLT2 inhibitor trials to do a meta-analysis, and that's why we had applied for access. The notations and the data dictionary within YODA are sometimes not as comprehensive as they are perhaps through the NIH data repository. And so I do think that there are some advantages to identifying collaborators who may have been involved in these studies, just so that you can understand the data a bit better. So I'll leave you with some take-home points. I think there are many publicly available research databases already that are people may not think about using, but could be used and leveraged to conduct your research. I think with the 2023 data sharing rules and policies, there will be more and more of these over time. There is quite a bit of a learning curve to using these databases. And so having someone who may have been involved in the study is always helpful. It's not that you couldn't do it without a collaborator, but if you have questions, sometimes it's a little bit harder to get assistance with, the exact questions about the variable through the repositories themselves. And so that collaborator could be someone that would be a useful resource. I do think more and more of these data sets will become increasingly available over time, and it's a great resource, but you do need to invest a little bit of time to learn about the data set and what is and isn't feasible within the data set. And so oftentimes, if you don't have funding or you're starting off, I think that this can be a very useful opportunity for you to conduct research and answer clinical questions using any of these data sets. I'll go ahead and stop here, and I think we have some time for questions. Thanks for listening.
Thank you so much, Dr. Koo. That was an outstanding presentation, taking us through to how to access the databases, how to navigate them, and finally, how to leverage them to address questions. Really, really appreciate your talk. While we wait for questions to come, and I don't see any hands at this point up, maybe I can ask a question in general. As the potentially individuals who are early stage investigators or are intending to do pilot projects, navigate the vast number of resources that are available, do you have a recommendation about how to first approach selecting the type of database that may be appropriate, again, recognizing that many are accessible and available, and the benefit and downside of some of these. Any suggestion would be really appreciated.
Yeah, I think when you're trying to decide which data sets you might want to access or include in your study, it's important to first search the repository for data sets that are even remotely related to your topic. And then I think going through the data dictionaries is important, because you may find that many of the data sets don't actually have the variables of interest. Certainly there are many of these data sets that are available, but my personal recommendation is that you start with the cleaner ones, where people have invested a lot of time in putting together data dictionaries that are really comprehensive and easy to use, or else it can be challenging to navigate some of these data sets. And so for that reason, a lot of the NIH data repositories may be more suited for those purposes, because they tend to have had a lot of people go through and double check the data, make sure that all the variables are clean and that the formatting is correct, and that it's clear what the data elements are actually, how they're collected and what information they're providing you with.
Thank you. Maybe a follow-up question, thinking through the processes that you explained, including requests for obtaining access, the review of the materials, et cetera, and the timelines that one would require in preparation of a grant submission, for example, or in completing a project, whether it be preliminary data for a submission of a project or just mining the data. What are your, in your experience, what are your thoughts about expecting timelines or anticipating timelines to accomplish that?
So from submission of a data request to getting access to the data, that will depend on your institution, and usually the time barrier is the Contracts and Grants Office and how long it actually takes them to review the data use agreement, in addition to getting institutional review board approval. And so it's usually about 3 months that it takes to actually get the access to the data, because the IRB has to review it, and then you have to submit the approval, and then you need to get Contracts and Grants to sign off on the data use agreement. And so if you want to, in addition to that, put together preliminary data for a grant submission, then you'll need to leave yourself another couple weeks to get some familiarity with the data sets, so that you can actually conduct the analyses that you need for preliminary data. But this will, of course, vary with how fast your institution's IRB is, in addition to how quickly Contracts and Grants can help you sign off on the data use agreement.
Thank you. Another questions that may potentially come up have to do with thinking through and you mentioned this several times, additional resources that could be utilized to help with a better understanding of the databases. One such being engaging collaborators. Recognizing that many individuals have contributed to these projects oftentimes, do you have any recommendations for early stage investigators as to how to identify potential collaborators that may be specifically helpful to their projects?
Yeah, that's a great question. I think if you don't know anyone, but you want to use a data set, I would look for who's published in the areas that you're interested in. I think with most of these large cohorts and trials, people are certainly happy to help out. And so the first step might be to identify the lead author on a paper or manuscript on the topic that you're interested in, but maybe isn't exactly what your research question is. And then see whether or not you can engage them in a conversation about whether your research study is feasible within the cohort that you're interested in or the trial that you're interested in. And oftentimes people will respond, and that may be one way to engage them. And sometimes they'll even say, well, why don't we just do this through the Data Coordinating Center? rather than going through the public repository, depending on, whether or not the data are actually available within the public repository, and also whether or not this investigator happens to be interested in your question as well. So that's probably where I would start. The other useful tip would be to email the individuals who run the data coordinating centers if they're still in existence. CRIC and CKIT, for example, are studies that are still ongoing, and so they deposit their data every couple years within the NIH public data repositories. But because they have working relationships with the NIH and they're under data sharing agreements with the NIH, they would be good resources for you to reach out to ask the questions about the data set and potentially get assistance with questions that you may have, but also to see whether or not they would be willing to collaborate with you depending on what the question is.
Thank you very much. I do have a question related to the question raised by me. How long did it typically take you to apply different kinds of data, biospecimens, et cetera?
Yeah, that's a great question. The biospecimen takes much longer. Mostly because one, there's going to be a lot of back and forth with the biobank as to what kind of specimens you're looking for. They'll ask you a lot of questions about which visit. It may take them some time to locate and count how many samples they actually have. They usually also try to come back with how much the quantity that's left over of whatever biospecimens they're actually looking for. And so that in itself can take a couple weeks just to sort out, is the biospecimen even available for the research question that you're hoping to answer? And then after that, once they confirm, yes, we have the biospecimens, yes, we think, you could use it for your study, then it depends on how long it takes you to write the protocol, but that can take a couple of weeks for submission. And then again, you'll still need to go through the IRB process in terms of getting approval to conduct the study, and you'll still need to go through contracts and grants. And so that's the typical 3 months that we just described. And then after all the approvals actually go through, you then need to get them to ship the specimens for you to the actual lab that will be performing the analysis, depending on what kind of assay it is that you're trying to do, especially if it's a super subspecialized assay that's only performed by one lab in the US, for example. That shipping time and analysis time will add to your time. So I would say it's probably a good 6 months before the whole process will go through. And sometimes it can take longer than that because it also depends on what the lab's capacity is and how many specimens you're hoping that they will run for you.
Thank you. Dr. Herbert, did that address your question, or is there any additional questions you may have about the specimens? Okay. Maybe one additional question, Dr. Koo, that has to do with there may be roles or responsibilities that the mentors can play potentially to facilitate the process, again, recognizing the complexities of access to such data sets and specimens. Do you have any recommendations in that regard for our mentors that may be present on the call?
Yeah, for mentors, I think, again, it's helpful if you have some connections or networks that you can help introduce your mentee to, who may be able to help answer questions about the data availability as well as the data variables that you're interested in. I think in general, walking mentees through the process is helpful because it's not that easy to navigate when you first try to fill out, for example, your data use request form. I've filled out many of these, but I've realized over time that they probably don't require as much detail as I was initially thinking. And so if you've had that experience yourself, then you can certainly provide more guidance to your mentee. But those are the main suggestions that I have for mentors. The other thing is also just recognizing that these data sets are available and sharing that information with your mentees can be helpful. So when I was a mentee, my mentor had actually suggested that we do our analyses through the data repositories, which I didn't even realize existed. And then my mentor connected me to people who were part of these these cohorts as well as these trials too. And then I was able to ask questions through my mentors, collaborators, in order to use the data. So I thought that was incredibly helpful. I think it's also important though to set realistic expectations. The use of public data sets takes time. There's time in application for use. There's time and learning curve. So this is not going to be a project where you're going to be able to turn around a manuscript within 3 months. It takes a bit of time to just even get familiar with the data sets. When you download it, it comes with these big folders on all these data sets. And so you do have to play around with the data a little bit to understand what's actually going on. And so this is probably not the best project if you are trying to help your mentee get a publication out within a couple months. It's a good investment of time because once you learn to use a data set, I think you could write many different papers as we have over time, given that we have the know-how now. But upfront, there will be some investment of time. And so I usually tell my mentees this will be sort of a side project where, as there's downtime, you can work on this and play around with the data, but it may not be immediately fruitful, though in the long run, it could help your career.
Wonderful. Well, I don't see any further questions, and we're at the top of the hour. We really, again, appreciate your presentation and grateful for all the learnings. Thank you again, Dr. Koo.
Thanks, everyone. Take care.
Bye-bye, everyone.